Hello, my name is Scott Smith, and I'm a technical consultant with the Centers for Behavioral Health and Justice. And today we're going to talk about the terminology common to the use of assisted outpatient treatment. These are terms that frequently are brought up or used and might not be familiar to everyone. So we wanted to make sure that you had a resource to better understand what is meant with some of the terms, some of the diagnoses, vernacular that comes up. Mental illness terminology. We're going to start with a definition of mental illness, because while we use this term often, we miss a few very important details. And we're also going to need to differentiate mental illness from serious mental illness. So to begin, when we talk about mental illness, we're referring to a maladaptive pattern, psychological, emotional, and/or social behavior. It's not related to someone's culture or development stage. It's considered maladaptive because it results in some type of impaired function somewhere in their life, such as their social relationships at work. For something to be a mental illness, it's important to remember that there has to be some type of impairment, right? We often feel anxious, but that doesn't mean that we have an anxiety disorder, which is a mental illness. So the key point, maladaptive. It's not helping us function. Now, serious mental illness is a certain form of designation for mental illnesses that happen to occur in ways that are so severe and extensive that they ultimately prohibit someone from being able to function meaningfully in usually multiple areas of life. And it's so encompassing, so limiting, that they're often considered legally disabled. And as a result, may be eligible for certain benefits. Now, the most common diagnoses associated with serious mental illness are schizophrenia, schizoaffective disorder, and bipolar disorder. And I'll explain briefly what those are a little bit later. Serious mental illness is sometimes referred to as serious and persistent mental illness, or SPMI. Developmental disability, often abbreviated DD, is a broad term used to refer to disorders that originate in childhood, teenage years, but result in lifelong functional limitations. An example of a developmental disability would be autism spectrum disorder. Basic physical needs. These are the needs that must be met in order to avoid harm to ourselves. Examples include hygiene, such as bathing and grooming, ambulating, moving around, basically getting around the house, and nutrition, eating enough. These are often referred to as our activities of daily living. There are other activities of daily living that are also important to keep in mind. So in situations where someone's mental illness is impairing their ability to continue with their vocational training or schooling, to continue with their employment, that's also an area of concern and something that can be considered when looking at the possibility of an assisted outpatient treatment. Psychosis. This term is used very frequently in media representations of mental illness. It's talked about casually, and I often overhear people using this term to refer to somebody who's disproportionately upset or offended. For example, wow, they were really angry. They were acting psychotic. But it's important that we understand that psychosis is altogether different than somebody's behavior or whether or not they're upset or irate. Psychosis is a symptom of many mental illnesses that causes an impairment in a person's connection to reality. And this results in their perceptions of the world, although false, appearing real. And because they seem real, people behave as though they are. And this is likely going to cause an impairment in some important area of functioning. There are a lot of symptoms that are included under the umbrella of psychosis. The two of the most common are hallucinations, which is where we're perceiving sensations that aren't present. For example, we're hearing voices, but no one is talking. And sometimes we experience a type of hallucination known as command hallucinations. These are auditory hallucinations that are giving some type of instructions to someone, hence the term command, often telling the person to do something, and too often telling them to do something that might result in harm to themselves or somebody else. One of the other more common symptoms is delusions. And these are false beliefs that someone holds. And although they're clearly not true, they're acted upon as though they were. There's no amount of information that can change their belief. Now, we distinguish delusions from somebody who holds a unpopular belief or might believe in a conspiracy theory. What we're talking about with delusions are things that could be factually demonstrated as clearly untrue and are unique to that individual. Paranoia is an example of delusions. And this is that situation where a person believes someone is trying to harm them in some way. Manic episode or mania. This is an abnormally and persistently elevated, expansive, or irritable mood that lasts for at least 1 week without intervention. When we're talking about mania, we're not talking about somebody just feeling great, feeling alive, feeling very happy. This is an extreme mood. And because it's a persistent state, the person experiencing mania is experiencing it most of the day. And since mania often results in a lack of need for sleep, most of the day could mean all day, every day, day after day. Common symptoms while somebody is experiencing a manic episode includes high levels of impulsivity, that is, acting without thinking. I'll define that more later. Hyperactivity, either in speech or within their actual physical behaviors. Decreased need for sleep, and an inflated sense of importance, something we call grandiosity. And this is not just somebody who is egotistical or overly confident in, who they are or what they can do, but someone who has a greatly distorted sense of importance, as though they're receiving instructions from some type of deity, as though they have an importance that most humans can't even begin to attain. Sometimes people might experience manic episodes that are less intense and shorter in duration, and those are conditions we call hypomania. Hypomania is far harder to recognize and see. So when most people are observing somebody having a manic-like episode, it typically tends to be full-blown manic state. Major depressive episode or depression. Again, we use the term very often, depression, to refer to feeling down, feeling sad, feeling blah. And while that's an element of it, what's unique about a true depressive episode is that it's that low mood and or a loss of interest and pleasure that again lasts most of the day, almost every day, for at least a 2-week period. And the reason we give very specific time frames before we make certain diagnoses is because we can be going through a difficult situation at work or in a personal relationship, and that can throw us off for a few days. But once we get to the point where this is lasting all day, every day for almost 2 weeks, it's obvious that that's going to start to greatly impair our ability to perform many of the tasks that we need to do, those basic physical needs that we need to meet. It's also going to impair some other area of our life, our ability to go to work, our ability to be a good spouse, sibling, friend, parent. And when you combine it with the other common characteristics, which are sleep disturbances, sleeping too much or too little, either a loss of appetite or a dramatic increase in appetite, and impairments in our ability to perform cognitive tasks like remember things or even the speed at which we can process information. It's not hard to understand why this can result in such significant levels of impairment. Impulsivity, as I started to mention when I was describing the symptoms of a manic episode, is a symptom that is characterized by acting without considering the consequence. And it's not that we might not all sometimes just decide to do something fun on the spur of the moment. The hallmark here is that the consequence of acting without considering the consequences is that it places us at a greater risk for some type of harm. High levels of impulsivity are a serious concern because it reduces our ability to kind of determine what we could reasonably expect somebody to do or to not do. And it's especially important when we're considering somebody who might be having some type of thoughts around suicide. Crisis. Again, this is a very commonly used term, but in the mental health world, we're referring to a condition where somebody has exhausted, that is, they've used up their ability to cope with the psychological/emotional demands that they're facing. A crisis state is a truly vulnerable state because someone no longer has any natural way to handle all of the challenges they're facing on that psychological level. And as a result, they are very often suicidal and or homicidal when in a crisis state. Suicidal ideation is a common feature of many of the mental illness, mental health symptoms we have been talking about. And this refers specifically to the thoughts a person has of ending their own life. Sometimes these thoughts are active, such as, I want to kill myself, but other times they're what we would consider passive. That is, wishing that they would die or wishing that, they were never here. We want to pay attention and always respond with empathy and concern anytime somebody expresses any type of suicidal ideation and help them get resources to keep them from going any further with those thoughts. Suicide attempt. Suicide is a spectrum of behaviors, a continuum, if you will. And a suicide attempt we define as an intentional, serious effort to end one's life. We include the definition of suicide attempt here because we want to underscore that there's a strong relationship between prior suicide attempts and future suicide attempts. So often when you're considering whether assisted outpatient treatment is warranted, if there's been a history of suicide attempts related to a person's, unwillingness to adhere to treatment or their inability to recognize the need for treatment, that's a pretty good indicator that an AOT is probably a good idea. I'm now going to talk about some of the diagnoses that are common to assisted outpatient treatment workers. Now, you can have other diagnoses with an assisted outpatient treatment order, but these are the conditions that are most common and the ones that often result in the criteria necessary in order to qualify for assisted outpatient treatment. And the first one is schizophrenia. And this is a mental illness characterized by recurring psychotic episodes that greatly impair a person's ability to function. People living with schizophrenia often exhibit bizarre behavior, are difficult to communicate with, and are resistant to treatment. As a result, they very often go untreated, which not only makes their condition worse, but makes it harder in the future to treat the condition. And there's also emerging evidence that this lack of treatment can result in a greater susceptibility to other harms down the road. Bipolar disorder. We used to call this manic depressive disorder. And my personal opinion is that when we used that term, it was actually far more clear. Bipolar disorder is a mental illness where an individual experiences both major depressive episodes and manic or hypomanic episodes over the course of their life. And I want to be very clear here. I often hear people refer to somebody who is moody or has big mood swings as bipolar, but that's not what bipolar is. Bipolar requires the presence of both a major depressive episode, which we defined earlier, so that minimum of 2 weeks of low mood, loss of interest and pleasure, and those other symptoms. It also requires a manic or hypomanic episode. And individuals who are living with bipolar disorder may not have many depressive episodes. They might primarily have manic episodes, or they might primarily have depressive episodes and have had a manic or hypomanic episode. But the point is that we're not talking about simple moodiness. And they don't transition between these moods very quickly at all. This is not, they were depressed in the morning and manic in the afternoon. That's not what bipolar is. People can be moody often because of depression. So for bipolar disorder, it's very critical that we understand it's both major depressive disorder symptoms and the symptoms of a manic episode or hypomanic episode. That brings us to schizoaffective disorder, which is a rare condition. And it's essentially kind of a combination of both schizophrenia and bipolar. So there's the schizophrenia symptoms, that is, there's the recurrent psychotic episodes combined with mood symptoms. Now, they don't have to have had both major depressive and manic hypomanic episodes. There are specifiers, whether they, are primarily depressed, primarily manic, mixed episodes. But what's clear is that they're presenting with symptoms that could go either diagnosis of schizophrenia or bipolar disorder. This is usually not a starting diagnosis because of that. Often people begin being diagnosed with bipolar disorder, but the presence of psychotic episodes leads their provider to believe, oh, maybe this is schizoaffective disorder. Substance use disorder, often abbreviated SUD. Substance use disorder is an ongoing pattern of substance use resulting in distress and or the ability to function at least one area of life. Again, social, occupational. Sometimes this is presented in a substance-specific way, such as alcohol use disorder or opioid use disorder. And again, the substance use disorder is an ongoing pattern. The diagnosis of a substance use disorder typically requires, a longer period of evaluation, 12 months typically. And it's important to recognize this because there are people who might go through phases and they're concerning and they definitely need help, but that might not rise to the level of a formal diagnosis. People may use substances recreationally. And while we might want to promote healthier behavior, it's important to recognize that that in of itself does not rise to the level of a substance use disorder. I'm including this because while it is not a diagnosis that in of itself can be used for assisted outpatient treatment, approximately 50% of individuals living with a serious mental illness have what we call a co-occurring substance use disorder. That is, they have their mental illness and a substance use disorder at the same time. Thank you for taking time to view this training. This training is presented as part of the Michigan Assisted Outpatient Treatment Toolkit. And to learn more, visit behaviorhealthjustice.wayne.edu/AOT.